Hi, Dolores. I see that you're here. Oh, no, that's you in another post. But here you are anyway. So thank you very much for coming early, usually do. And I saw you, okay, on YouTube as well just a few moments ago. So thank you very much, and please do share. We will both appreciate that. We'll be doing some sharing ourselves, and we'll be with you in just a few minutes. Well, the internet seems a bit slow tonight. Okay, thank you all for coming. My guest for tonight is Dr. Joseph Q. Jarvis, who's a physician. He's the author of The Purple World: Healing the Harm, the harm in American healthcare. He's also a Red Beret and a supporter of the whole Washington movement. At this point, I'm going to turn things over to Dr. Joe to tell us more about himself. So go ahead, Joe.
Well, thank you.
Please do.
Yes, I am a physician. I'm a public health physician. That's where my career has been. Sometimes in public agency like OSHA and state health departments, where I have served in various capacities. I came to the practice of medicine first, though, as a family physician. So I did the full range. I took care of obstetrical patients and delivered their babies, and then took care of the babies. And for a while, I was the only physician in my community doing home visits for the elderly. I've also taught at various schools of medicine and done a little bit of research and publishing. And I served for a while as a member of a staff of an academic medical center, the National Jewish Center in Denver, Colorado. I tell you all this by way of informing you that I think I've seen healthcare from a variety of perspectives, maybe most of the perspectives available. My family, like all families, has had people ill and injured, and so I've been at their bedside as not their doctor, but as a family member supporting them. I myself have been ill and hospitalized on occasion. So I think I see and have seen American healthcare from lots of different perspectives, and I've come to the conclusion that it is harmful. It's a mess. And it is killing people, it's killing family finances, and it's going to harm our governance. We are riven apart in the United States, I think in large part because we're just not caring for each other. So I'll leave it there, and I'm sure we've got a lot of things to talk about.
Okay, thank you, Dr. Joe. I would go, what I'd like to do is to go a little more deeply into some of the statistics that can bring home to people how terrible the situation is. But in the video that you did, I guess, okay, I'm not sure exactly the date, but it's the 37-minute video,
Right.
That you did from your home. You mentioned that the fatalities due to poor quality health care, specifically to errors, come to roughly 400,000 a year. Could you expand on that, please?
Sure. One of the things that we Americans in general misperceive about our healthcare system is the level of quality in the system. Most Americans would like to believe that we have high quality healthcare. In fact, they would argue we have high cost because we have high quality. And in fact, that's not the case. Since at least the 1990s, the National Institute of Health and the Institute of Medicine have pursued studies about medical errors and patient injury. So the data about 400,000 injuries per year caused by medical errors and therefore due to preventable injury of hospitalized patients, that's a statistic that comes from the National Institutes of Health. A more recent recap of the same kind of study conducted at Johns Hopkins University in Baltimore estimated 250,000 deaths per year due to preventable injury of hospitalized patients. So a downward estimate a little bit. Nonetheless, that would still make it the third leading cause of death, either the 250,000 or the 400,000 mark per year. Poor quality care resulting in preventable injury of our hospitalized patients, leading to preventable death at the level of just below the rate of death due to heart disease or cancer. That's a remarkable finding about our healthcare system. It's more true of the United States. Medical errors occur in every healthcare system, but it's more true of our healthcare system apparently than is true of other first world nations. That's one of the reasons why our healthcare costs so much. It's not because of great quality. In fact, poor quality care costs more. Good quality care is actually less expensive. There are a couple of other varieties of poor quality care. One is failing to do the right thing for patients. The thing that clinical science has taught us is the correct thing to do.
Yes.
For instance, as a patient coming to the emergency room with chest pain should be given an aspirin tablet. That should be universally applied. It should always happen. And apparently, according to some studies that I've read, about half the time we actually get around to doing that thing or all of the right things that could be done no matter what the healthcare setting is: operating room, intensive care unit, emergency, primary care office, et cetera. We fail to do the right thing for our patients. And the third major category of poor quality care is providing care that's not likely to actually clinically benefit the patient. That is, being more aggressive than the clinical data warrants. We have variations in the delivery of virtually all interventions in the United States, like all kinds of different surgeries. We have variations that are orders of magnitude different from one geographic area to the next, not driven by epidemiological or clinical reasons. They are driven instead by what the healthcare system wants to sell. When you have a for-profit healthcare system, you're more interested in making a sale than you are in actually taking care of a patient. So we do too many surgeries of various kinds, and that leads to poor quality care where the outcome can't really be improved by the intervention, and yet all of the risks associated with interventions are nonetheless occurring. So there are various estimates I've seen out there, but something between $500 billion and $700 billion a year in the United States is wasted on poor quality care, and 250,000 to 400,000 lives are lost, probably more. That's pretty serious. That's something nobody talks about much, at least not among the general public. It's something they really ought to get better acquainted with.
Yes, I entirely agree. And I also note that this doesn't really speak to the situation where people cannot get care because they don't have insurance.
That's right. We tend to talk, when we talk about health system reform, it tends to be about coverage, with noticing how many tens of millions of Americans have no financing for the health care that they need. And that coverage comes with some loss of life, or lack thereof. Lack of coverage comes with some loss of life. People who can't get care because they can't finance it, who have diabetes or hypertension, some of these chronic conditions, end up dying of those diseases that are eminently treatable simply because they couldn't afford the treatment. That's also a problem. But my argument is coverage is not actually the primary problem in American healthcare. Cost is. If we did better quality care and we delivered it more efficiently, then we would not have a cost problem that barred people from entering the system with the proper financing for their health care. The irony of this is the American public is taxed more for health care than is the citizenry of any other nation. The people who are paying those taxes are the very ones who can't afford the care when they need it. That is shockingly unjust.
Absolutely, it is. I recently checked out the CMS estimates of what healthcare spending in 2021 likely to be here in the United States. Okay, and I noticed that it's now approaching $4 trillion. It is really that high.
Yes.
Okay. I also noticed that it's approaching 20%, okay, of our GDP as well. Okay. I also noticed that the similar figure for Canada, okay, is 11%, okay, of GDP. So, I also notice that Canada is far from the least expensive of the OECD countries. It's somewhere around, I guess, fourth or fifth if we look at it as a percent, okay, of GDP.
Yeah.
But the average is supposedly 9 or 10%, okay, of GDP, which is either half of what we spend or less than half, okay, of what we spend. If it were 9%, it would be less than half, okay, of what we spend. Okay, of course, the outcomes are also superior, okay, in these other countries, generally speaking, across the board. Except in a couple of areas, I think we have the worst outcomes when it comes to a comparison with OECD nations. So this can lead one to the conclusion that if we actually spent less, okay, but we did it right, we could have much higher quality healthcare. But also from the economic standpoint, we wouldn't get so much of GDP being sucked into the hierarchy of the healthcare industry, and much more money that would be staying in the pockets, okay, of people that they could use for other purposes that perhaps have a higher multiplier effect also as a higher fiscal effect, okay, in the economy, so that we might, by reducing healthcare expenditures, actually have an expansion in terms of the general well-being that the people. Well, we would probably have a greater amount, okay, of equality, okay, in our country, for one thing, and we would also have far fewer bankruptcies, divorces, mortgage foreclosures going on. Have you any comments on that?
Yeah, I like the way you said it. I guess I would reverse though and say if we did healthcare right, that is, with higher quality and more efficiently financed, it would cost less, and therefore we wouldn't need all of the money, all of that $4 trillion, and yet at the same time, every single American would have financing for the care that they needed. It's important to note that $4 trillion can be divided into public revenues supporting healthcare and private out-of-pocket revenues supporting healthcare. And by far, the vast majority of our $4 trillion in healthcare are due to revenues generated in the public sector through taxation, either at the federal or the state level.
Yes, well, there was a study by Himmelstein and Woolhandler a few years back that showed a figure of, I forget exactly what it was, 2.5 trillion or 2.6 trillion that was being spent, okay, by governments, okay, at all levels, out of total healthcare spending. At the time they did the study, I believe our total spending had reached something like 3.6 trillion. Right. So 2.6 trillion out of the 3.6 trillion was actually government spending.
Yeah, we're approaching 70 to 75% of the dollars in healthcare being generated by taxation. That smaller slice out of pocket, private out of pocket, is either coming out of individual families' budgets or through their employers. But you have to realize quickly that the employer's part is being subsidized by a very remarkable tax credit, which is through the federal tax code.
Yes.
That tax credit amounts to, and I've heard varying estimates of this, and nobody seems to be able to actually talk about it very specifically, somewhere between $300 and $500 billion a year tax credit. In other words, the private for-profit health insurance industry that's so based on employment, health benefits, is tax supported. It's not a private market in any real sense of that word. It exists because the taxpayer largesse has allowed it to exist. The other thing to remember is the part that comes private out of pocket of individuals and their family budgets. That's the part that's killing the family finances, that's sending them into bankruptcy, and that's making it impossible for them to make their mortgage payments, and causing all the financial distress and injustice of not being able to get care after being taxed your whole life for medical care. That's what's wrong with this system. We don't need that private money. We have enough money if we do high quality, highly efficient financing of healthcare. We have enough money in the public sector. We already tax ourselves enough. And that, in fact, that amount of money on a per capita basis or a GDP basis still leaves us as the most expensive healthcare system in the world. We're still better funding it. It is well past time for Americans to realize they're getting fleeced. This is ridiculous. It's such a bad deal. Let's do something about this.
We are getting fleeced, and we do have to do something about it. We've been getting fleeced for a very long time. Okay, but what we also have to realize is when we say there are private dollars in the system and there are public dollars in the system, we also have to realize that the government is not doing any deficit spending when it comes to health care. So in other words, that government money we talk about is getting offset by the taxes they levy on private sector people. So in one sense, okay, or other, all the money that is generated by the government for healthcare corresponds to money that is being taken out of our pockets. I'm putting it, okay, in such an unwieldy way because, of course, from the MMT standpoint, taxes do not pay for anything.
Right.
Okay, because actually the Fed is creating new money all the time to top up the Treasury. Okay, and though that money corresponds on a one-to-one basis with the tax money, it is not actually the tax money because the tax money is destroyed, okay, in settlement. But the point, okay, I'm trying to make here is that one way or another, that money is still coming out of our pockets, whether it's the exact money which is being used to pay for things, okay, or not. And that's true because there's no deficit spending, okay, in healthcare. They have made it. They've been very, very careful to make it the case that whatever the government spends on healthcare corresponds to money that is coming out of our pockets. So that is part of the fleecing. They may be doing all kinds of deficit spending for military stuff, all kinds of deficit spending, okay, for some other kinds of spending, but they're not doing that when it comes to healthcare spending.
Yes, I'm only barely becoming acquainted with MMT, and I thank you for your correction and added insight into that. As I've become better acquainted with MMT, I've been better able to respond to people who seem to be driven by fear of the deficit and the belief that somehow we can't afford health care because it's too expensive, for the public to pay for, which of course is nonsense. We can afford this. We absolutely can do this, and we can do it well, especially if we do a high quality job of delivering care and we finance it efficiently, meaning without the for-profit health insurance business motive.
Yes. There's also something, okay, that you should know, okay, about the MMT attitudes about this. The MMTers, okay, who are at the top of that approach are convinced that if we went to a single payer system, but to a Medicare for all system, it would actually be deflationary because the government, they believe, would be spending less than it is spending now.
Well, again, if they base that notion on improving the quality of care at the bedside so that there are less patient injuries, there are fewer of these interventions that are not clinically based, and there's a more uniform application of clinical science, so the right thing happens to the right patient at the right time uniformly. And they also base that on a financing model that's efficient, as opposed to the ridiculous overheads of today's health insurance business model. Then they're right. It will cost less. Absolutely. I mean, by hundreds of billions of dollars per year, it'll cost much, much less.
Yes, and if by the way, we were to get down, like say, to something like 12%, okay, of GDP or 13%, okay, of GDP spending, well, fairly obviously that would amount to 14, 15, 16 trillion dollars in savings compared to what we spend now over a 10-year period.
Yeah.
In other words, it's actually more than $1 trillion a year. It's more like 1.6 trillion or 1.7 trillion. But what goes on in making the economic estimates is that the people who make them always want to be conservative in terms of the estimates, I mean.
Yes.
The reason why they do that is because they're afraid people who do not favor single payer are going to call them out, okay, on the estimates. So at each step of the estimates, they're conservative. Since the estimates, okay, are basically bottom-up estimates, there's a conservative bias to the estimates, at each level, okay, of estimate. So the overall savings estimate that comes from someone like a Jerry Friedman, okay, or somebody like that, is going to be more conservative than it has to be, and is going to underestimate the amount of savings that we are likely to realize in the long run. Okay. And the way you can see this is just if you take a macroeconomic standpoint, okay, and you look at it, some other nations that are doing 10%, okay, of GDP, okay, and you recognize that could be us, why that means we'd be cutting our spending in half. If we're spending $4 trillion now, we might be spending only $2 trillion or 2.1 trillion or 2.3 trillion. And that's where the 1.7 trillion per year or 1.8 trillion per year, even 2 trillion per year would come from.
Yeah. Yeah. So there used to be what's, a policy discussion around health system reform that was called the Iron Triangle. And what that was considering three principal aspects, and that is access, cost, and quality. And people who would argue about this Iron Triangle would say you can't do one of those improved quality without affecting the cost, meaning they believed that would increase the cost, and therefore that would decrease the access. And no, likewise, if you increase the access, you'd increase the cost, and therefore by force decrease the quality. What I'm trying to teach is, in fact, the Iron Triangle is a myth.
Yes.
You increase the quality, you decrease the cost. That is our way towards actually doing the right thing. Now, what I'm calling quality waste, which means poor quality care costing us more, that extra that it costs us is called quality waste. What I'm arguing is quality waste is actually in the hands of the medical industrial complex, that large group of corporations and others who are feeding off of this. That's their method of getting ridiculously high windfall profits. They don't think of it as waste. That's their money. That's how they enrich themselves. That's how they steal from the American public. And that's how they turn around and use a good chunk of that to defend the status quo.
Yes.
What I'm trying to say is the Iron Triangle is a myth. It's propagated by them. They're making us afraid of health system reform by telling us that inevitably it'll cost us in quality or access or something, or it'll be more expensive. Wrong, wrong, wrong. We do this right. We get everybody's lives improved. We start taking care of each other. We put hands on each other, and suddenly we are a society again. We all have a dog in the fight. We all embrace each other, and things really move forward. And you've already begun to point out what the economic consequence of this would be. It would be a huge growth in the economy. People wouldn't be tied to jobs. They wouldn't be losing their houses because they got cancer. All kinds of things would improve. Their wages wouldn't be taken from them in order to pay for higher health insurance costs. All kinds of things would dramatically change. And the federal budget would at least stabilize in terms of healthcare costs, if not go down and deflate.
Yes. And by the way, the moral consequences would be very, very important as well, because right now, the way the healthcare system, okay, is run, it is such a heartless thing, okay, and everybody who's involved in it and who contributes it sees the heartlessness of it, and it must be terribly discouraging, okay, to providers, to doctors, okay, and to nurses to see this going on every day, and to try to fight it every day, and to realize that there are human problems in making the fight, and that it just gets very, very discouraging over a period of time, and people really get extremely burned out by it because they're constantly fighting with the administration and with the business side of healthcare to get the freedom to actually deliver good healthcare. That must be terrible for people who are experiencing that each day. And I consider myself to be very lucky instead. Okay, let us move on a little bit to You've gotten very involved with the whole Washington movement, okay, and as well um, the national movement, okay, for Medicare for All. Okay, so tell me about those experiences and how they affect you, okay, from day to day.
When I was the state health officer of Nevada, now 30 years ago, I was doing public health leadership in a state right next door to where I trained, which was in Utah. And in Utah, I was used to a very highly technically competent healthcare system. Utah had just been the home where the first artificial heart had been implanted, for instance. There was access to highly skilled trauma care. There was trauma centers designated, perinatal services with urgent care needs all over the Intermountain West were served in Utah. Those patients were brought to Salt Lake City. The burn unit for the Intermountain West is located in Salt Lake City, etc. The care seemed expensive to me, but nonetheless, it was good, at least so I thought. And then I moved next door to Nevada, where I discovered that healthcare costs were on a per hospital per bed day were 2 times as much as they were in Utah.
Oh my God.
I immediately encountered this because when we moved, when our family moved, my wife and I were expecting our 4th child. I knew what the labor and delivery costs had been in Utah, and I was astonished at what they were going to cost in Nevada. And right off, as I started to meet people in the medical community and get acquainted, the pediatric community in unison said, noticing we were expecting a baby, said, if there are any troubles with this pregnancy, don't deliver the baby here. We have terrible newborn intensive care unit care. Go back to Salt Lake and get the delivery done there.
Oh my God.
And when you say that to, a public health official, I kind of ask myself, how is it possible that care can be so expensive here and yet so terrible, so bad that the medical community is warning you away from it? And of course, I ended up discovering ultimately that the reason for that was poor quality care and the for-profit motive, which was much more prominent in Nevada than it was in Utah. Poor quality care actually costs more. That's the problem. There's stories in my book, The Purple World, about how I tried to improve things through legislation, et cetera. But as I struggled with these concepts and tried to grapple with them, and I come at it as a conservative, born and raised that way in suburban Scottsdale, Arizona, influenced by Barry Goldwater, and his pitch of conservatism, which was a moral pitch.
Yes, I know it was.
Justice pitch. Let's take care of each other kind of pitch, biblically based. He wasn't either Christian or Jewish. He came from both kind of people. His parents were one was Christian, one was Jewish, but the Bible meant something to him, and it's the constant phrasing there in the Bible about taking care of the sick, taking care of the alien, taking care of the orphan and the widow. The predictions of the prophets saying our society and the kingdom of Judah is going to die if we don't start taking care of the people who are hurting. Jeremiah saying, "For the hurt of my people, I am hurt." And where's the balm in Gilead that we know everybody should be having? Well, I was struggling with all this, and I happened on Physicians for a National Health Program, and learned. You've already mentioned Himmelstein and Woolhandle, and learned from them at their conferences how to articulate this and how it fit together with their discovery of highly inefficient services and poor quality services. There at Physicians for a National Health Program, where I became a member of the board of directors for a term, I learned about state-based health system reform. Marcia Angel, who was then the chief editor of the New England Journal of Medicine, came and spoke, and she said, yes, the goal is national health insurance. The goal is Medicare for all. But politically, maybe we'd be smart to think about it as something we would try out at least at 1 or 2 or 3 states first, and then try to push for something that kind of sweeps the nation. And she mentioned how that was true of the Canadian transformation from their single payer to what happened afterwards, beginning in Saskatchewan. That's where I first happened on the notion of state-based, and because I'm coming from a conservative base, it resonated with me. That's the kind of mindset that conservative people will interact with. In Utah, where I do most of my activities related to health system reform, I can't have a conversation with very many politicians, if any, on the basis of trying to make it Medicare for all. None of them will even listen to that. But they will start out, if I start out by saying, you know what, we in Utah have particular needs. We're different. We have this vast outback sort of area that's frontier with very few people, but millions come and visit our beautiful national parks. We've got to deliver trauma care there somehow. That's totally unlike what happens in Massachusetts, which with much more concentrated populations and academic centers, et cetera. So they're the highest per capita cost in the nation. Utah's blessed to be the lowest per capita cost. Let's see if we can try to get the federal government out of the way and let us try to help everybody get healthcare here in Utah. That conversation I can have, and I have had with members of Utah's very conservative Republican congressional delegation. Now, I haven't got them to endorse it completely yet, but they're at least talking to me. That's how I started. So I started looking around the nation for colleagues. It's not that I'm opposed to national health insurance. I'm not. That's the goal. That's what I want to get to. If I could see an easy political way to get there, that's what I'd be doing. I looked around for people who were in the state trying to argue what I was arguing, and I found whole Washington. And it's been wonderful to meet those colleagues who are so full of energy and so intent and so well developed in what they're trying to propose. And there's others. I've been to Oregon where they have a similar movement. I've talked to people in North Carolina. I hope to go to other places that have movements like Maine and New York and interact with them as well. This is how we get local people to understand, get educated, and get involved and actually start demanding feet to the fire from our politicians something that's different, that's a change, that's substantive, and is sustainable.
Yes. How would you compare the strength of the movement, in Washington to other states out west, such as Oregon, such as California, Arizona?
Okay, so I've been to Arizona too and spoken to them. They're like Utah in a very nascent stage. Nevada, likewise. California has a well-developed movement that's actually brought ballot initiatives to the ballot at least once, I think twice, and several pieces of legislation have gone to the legislature and even passed, although then were vetoed by the governor. I think it was Governor Schwarzenegger.
Yes.
Oregon is on an earlier stage than that, and earlier than whole Washington, than the state of Washington is. They are hundreds of people together in Healthcare for All Oregon, and they have developed a plan, but they're using a legislative process to create a study commission and sort of early steps towards fashioning legislation, hoping to get it through the legislature, which is not a hope that I share from in my state of Utah. So I would say Washington is the state closest to doing a ballot initiative, which I value that process. You get the whole citizenry involved, and that means that they've bought in if it passes, as opposed to something that comes out of the legislature. Oregon is full of really good, great energy, great people, but they're a little bit, further back from where whole Washington is. In California, there's so many things that have already gone under, water under the bridge that some of the people, I get the sense that they're beginning to be cynical about it and wonder if anything can ever make a difference. So they may be even sort of a later stage than Washington and not necessarily a good one.
Yes, I've often thought that in California, it's really similar to the national problem, which is to say there may be overwhelming support, on the part of people for single payer. However, the leadership, the cadre at those levels is very much supportive of the donors and very supportive, of the system we have now, and that they stand in the way. People have told me that with respect to California specifically, yes, they will pass a single payer bill when they have a Republican governor.
Right.
If they have a Democratic governor, then the leadership of the Democrats will block the single payer bill and protect the governor. Okay, so the governor, who may even have run on single payer, has an excuse not to sign the bill because it never got to his desk.
Right. This is exactly what I meant by the cynicism. California is overwhelmingly Democrat majority. And yet, even in that place, they can't seem to find a way to make it happen, which leads to only one conclusion, and that is that the elected Democrat politicians don't actually want it to happen. They talk a great game, but they don't ever do anything when always have the opportunity in California. That is the cynicism that is hurt. It's hurtful. I have for a long time.
Yes, it's also hurtful to them in certain ways. Okay. For example, I wonder whether Newsom would be facing a recall now if he had kept his promise and supported a single payer bill and turned some of the legislative people around on that. If he had gone through the whole state campaigning on it, really trying to get it passed, he probably could have passed it. Had he passed it, his results on COVID would have been a lot better than they've been. Some of the reason why he's facing a recall, okay, is because of the mismanagement, okay, of COVID. Some of that had to do with not having a single payer program. Probably people are angry at him as well because he had not passed a single payer program. And then, of course, there's the fire issues, okay, which are very big issues there. But he certainly would be in a much better position today and probably would not even have had a recall if he had passed a single payer health bill in California.
Yes, I agree that leadership on single payer would have reaped great benefits politically for Governor Newsom. And you're right, he ran on it and he cynically turned on the movement, ignored it, all the other things aside that you've already mentioned. And I'm not an expert on all the failures that were true of the Newsom administration, particularly in regard to COVID, but it's true. He simply failed on single payer, and that by itself is enough for people to turn who would have been his supporters, naturally would have been his supporters, to turn their back on him and give up on him. And so he got in the suit. I agree. I think
he broke a promise.
Yep.
Okay, and now he's sending emails all over the country trying to get people to contribute $3, $6, or whatever to his campaign, okay, because there's a possibility, a pretty good possibility now, that he's going to be recalled. And it's really, it's just his own fault.
I mean, from sitting from outside the state, I agree with you. Yes. That's what it looks like to me too. His own failures.
Okay, so let's consider for a moment what would happen if whole Washington was successful, say in about a year. What kind of impact would that have on the movements in Oregon and California?
I mean, because of a success like that, where it is shown to be politically popular, let's assume that they get it through on a ballot initiative, and a whole state's electorate weighs in on it and says yes. That's very difficult for hardcore conservatives who've all along said states ought to be able to do policy that's not explicitly given in the Constitution to the federal government.
Yes.
And that this is a 10th Amendment moment, and this is something that Goldwater harped on over and over and over again. If you don't give Washington a chance to do what it wants to do, constitutionally, are you conservative anymore? This is one of the things that I think people underplay. They don't understand what this dilemma this could create, and we could get moderates moving in the direction of freeing and voting for, in Congress, voting for things that would advance the single payer cause. That I think is transformational.
Yes, I think it's also transformational, but just in terms of single payer movements for Oregon, okay, in California, one success in Washington really buoy up those movements tremendously.
It would send shockwaves across the country. A lot more states would actually jump into the fray. The ones that are already there, like Maine and New York, and as you mentioned, Oregon and California, they start afresh and try to push it through. It creates a momentum. Yeah, absolutely. I'm excited for the people in Washington, though I understand they've slowed down a bit because of the surge in COVID that's currently going on. But I'm sure they'll be back when it's possible, and they'll keep
Oh,
going.
yes, I'm sure too. I'm sure too, okay, because we know that our friends there are very, very determined people.
Energetic.
Yes,
They're
hard
what
working.
in my religion they're referred to as anxiously engaged.
Okay, that sounds great. Uh, what I've been giving a great deal of consideration to, okay, is the dynamics, the interrelations, okay, among the states, okay, and the movement from the state level to the national level, back to the state level, to the local level, fighting, okay, on all fronts, for this, and trying to create an understanding, a conceptual understanding, a very deep conceptual understanding of how the forces of the movement move back and forth, okay, across the level, and how they fertilize those parts of the movement that are at the same level as they are. So there's a kind of cross fertilization going on, and there's a cross level movement, okay, that's going on, and it's all really one movement. It has to be looked at, okay, as an emergent movement that's happening, and it doesn't make sense to really isolate it, to just say, well, there's something state level that's going on, and or there's something at the national level going on. It's going on really at all levels because the same people are involved, okay, at all levels, and bringing their enthusiasm and bringing their work and bringing their communications to each of the levels. And so I'm concerned with the idea of how knowledge of how to do things and move the movement forward and faster can be gained through sharing knowledge, through meeting people, but through engaging, but through the one payer states site. But what do you see there in terms of the kinds of sharing that's going on?
I found one pair states almost kind of at random. Now it'd be just over a year ago, and discovered a group of colleagues who shared the vision that I have, which is we need to support people who, for whatever reason, don't have the reach to be at Congress and argue there, but they like to find people like themselves who know, as most Americans do, that the health system is in crisis. That's something that pollsters across the country have been finding as a true statement for more than 25 years.
Yes.
American health system is in crisis. People don't know how to articulate that crisis. They want to believe that their own doctor is taking good care of them. So if they're asked, is American healthcare good? They'll say, no, it's in crisis. What about your healthcare? They will tend to say, my doctor's good or my hospital's good. What they need help with is learning how to articulate that feeling of health insecurity, and what that means and why it's that way, and how their doctor's also a victim of it and their hospitals being hijacked for profit instead of actually for patient care. This is what one payer states is beginning to be able to do, all over the country. They have a group of people who get together and talk policy. And that's arcane, and not everybody's up for it. I'm not a policy wonk. But these people get down to the nitty gritty. They answer the question, what's right and what's wrong with each kind of proposed legislation? How can we improve it? What makes sense? We've got a group of people who are trying to help newcomers to the movement get the first steps of vocabulary so they can begin talking to their friends and neighbors. And they're helping finish off much more people who have been much longer in the movement so they can be public speakers and public writers on it, and join in at every newspaper with op-ed pieces, and be the people on the ground who do March for Medicare for All and organize it. So One Payer States is serving that function. It's a nonprofit, it's not political, but it is trying to serve that educational and policy-based center where people all over at the state level can come and find out what's happening in Maine if they live in Washington, and share and be able to meet people from all these various different places. It's all done by Zoom, of course, and be able to interact with them. It's efficiently done. One Payer States does this on a very low budget, I assure you. It makes it happen. Makes it happen. People don't have to feel like if you're going to be part of Physicians for a National Health Program, you have to be a physician. Well, there's got to be a place for a lot of people who are not physicians.
Sure.
Who can weigh in and kind of find a place for themselves. And One Payer States is one of those places.
Okay, so a specific question. Have they started actually sharing the bills that they're introducing into the legislatures? Is that sort of sharing going on?
You can find information about individual states and what's happening in them on the website of One Payer States. It's not as complete and detailed as I think it eventually will be. You have to think of One Payer States as a work in progress. But the answer to your question is basically yes, and increasingly it'll be even more.
Okay, that was what I was interested in getting at. I spoke to Georgia last night, and but she really didn't have an impression of that because she's more in the technical end of sharing technical things, of how to create a movement, how to push a movement, how to keep a database, all those kinds of things. And so she was not aware, of whether the legislative initiatives were getting shared from state to state.
The policy committee of One Payer States takes a look at legislation in detail and comments about it. That's another place where you can get information. They have a part. They have a part of the website is dedicated to the policy committee. So yes, the answer is yes. There is sharing of information. It needs to get better. It needs to become more readily accessible and understandable. But it's a start.
The model for this kind of thing is actually, I think, from ALEC, because they basically, when they want to influence the things that are going on at the state level, what they do is they create a model bill. Yeah. And they circulate, the model bill from state to state. And then this helps to create a movement inside of the legislatures for the kind of thing they would like to see. And I suppose the issue I'm raising here is, why can't we do the same thing with respect to single payer?
And we can. And again, the policy committee is about that. They have people. The chair is someone from Hawaii, which has a very unique sort of health system because it's a small contained space out there in the middle of the Pacific. And he's got people from California and Minnesota and Maine and New York sitting on that committee with him, and they go through fine-tooth comb style proposals for how do you do a state single payer, how do you manage various things, how do you manage the financing, how do you download the federal financing, et cetera. All of those things are carefully looked at. They consider various kinds of federal legislation too. It's a painstaking process. So over time, much more is going to be said and put up on the website.
Okay, very good and very interesting as well. Okay, so let's start to move to some of the comments here, because I think that people are very enthusiastic, about your coming here. and they've been making some comments straight along. So I'd like to consider some of those.
Okay.
Okay, let's scroll down here. But so Forever Love says Vermont governor could not make it happen in the state level. Suggested, okay, that the national route is probably the best route. Then Governor Brown of California agreed that state single payer will be difficult even in California and the great size of the California economy. Okay, I suppose I can comment on that. It has always seemed to me that Shumlin, okay, in Vermont, called in the wrong consultant. But Dr. Gruber was one of the architects of the Affordable Care Act. Okay, and he developed a model in order to predict how a particular program, okay, was likely to work out, which was perhaps appropriate for the Affordable Care Act, but whether that could be applied but to single payer proposals is actually debatable. And in addition, his model was a proprietary model. So it wasn't really transparent to people. In other words, it spit out something that said it would not be feasible, okay, but for Vermont to pass a single payer bill. But there was no way of examining the internals of the analysis to see what the conclusion, to actually critique the conclusion. But Shumlin seems to have accepted his advice without a full vetting of the analysis that actually took place there. Okay, so that, okay, is my comment on that. I doubt actually the validity, okay, of that analysis. There's some notion that says that small states cannot make a fiscally sustainable single payer program. The reason why I don't think that's true, okay, and I agree with Jeffrey Denton about this, is that there are very small nations that have not only single payer systems, but actually national health services. The state, okay, of Malta, which doesn't even have its own currency, it uses the pound, has a national health service, and it has a population of something like 448,000 people, smaller than the population, okay, of Vermont. So, but based on population, but based on strength of the economy, the considerations, okay, of that sort, it's hard to understand why it would be possible for Malta to do something like that and not possible for Vermont to do something like that. And there are many other small states that are able to afford by universal healthcare systems that are based on quality and that have very low costs and perform well. I think that Jeffrey Denton has found in a survey of this that there are 119 nations across the world that have universal healthcare systems. That's a staggering number. It doesn't suggest, okay, that the analysis that was made, I think it was back in 2011 or 2012, okay, in Vermont, it doesn't make sense that it could be a correct analysis. So that's
this notion that a small state can't financially make it in a single payer system is a sort of a different version of the iron triangle.
It is.
They're basically saying that it's a coverage problem, and coverage costs you more, and that cost is beyond what a small state can muster. And my answer back is, it is not a coverage problem. It's a cost problem, because we have overhead that's wasting hundreds of billions nationwide per year, and poor quality, which is wasting hundreds of billions per year. If we get the will to improve the quality of care we deliver to people and reduce the overhead to what it should be, which is far less than 5%, there's plenty of money in a small state, in a large state, in the whole nation. There's plenty of money and then some to take care of everybody. Money's not the problem. The problem is the political will to actually take care of people and do it efficiently. That's what it is.
Okay, I am also, but Lana Dell has made a comment, but don't forget John Marty, okay, in Minnesota. And so she's calling attention to the single payer movement there, which has been fairly active for some years. In fact, I remember Kip Sullivan advocating very strongly for a single payer movement, not just in Minnesota, okay, in the country at large, but back in 2009, 2010. Kip Sullivan was also a part, okay, of the Minnesota movement.
Kip Sullivan has made some of the better comments about the Vermont situation and what actually went down. I'm beginning to be acquainted with him through One Pair States. He's active on the policy committee, for instance. So yes, my bad. I don't know much about the organization he participates in Minnesota, and I'd love to actually get better acquainted with what they're doing there.
I am really familiar with his work. Is he produced what were the best critiques of the likelihood of failure, okay, of the Affordable Care Act, and specifically the public option idea. He wrote some critiques in 2009 and 2010 about that were really trenchant,
right,
and convinced me, okay, at that time, that the public option idea was nothing but a trick sparkle pony, and that it wasn't going to work. There was no way, okay, it was going to work. It was based entirely too much on but neoliberal principles. And I thought to make a remark earlier, the Bible is not a neoliberal document.
Okay. Yeah, so I make the point again, Kip Sullivan is the kind of talent that we have in One Pair States on the policy committee. And so the work that comes out of there is good work, solid policy work.
Good. Okay. So Laura says, Laura Fielding, this is, my parents are conservative and they live in Utah. They support my work with whole Washington, even more so than with the national movement. I'm just echoing Dr. Jarvis's comments that many conservatives are much more willing to listen to proposals of state-based single payer.
You know, a big mistake that was made by the Obama administration, and I'm not saying this because I support Obamacare. In fact, it's quite clear in my book, The Purple World, that I found it to be a useless gesture and not anything at all about reform. But their mistake was passing it without a single vote from the other party. It is flat the case that created 10 years of fighting over nothing useful. I know because I've tramped back and forth across the entire state of Utah, a very, very conservative state, and talked with people in rural and in businesses, in farms, everywhere, ranching, all of these, mineral extraction. You cannot get anywhere with them if you don't start with something other than Medicare for all. Now, they may eventually be able to get there, and I think that's the goal. So hopefully everybody will get there. But we need help from across the political spectrum. And it's a message because, I mean, single payer health system reform is a message for the conservative. It is fiscally conservative. It is morally authoritative, and it is justice. And those are conservative themes that have started with Lincoln, gone through Grant, gone through Teddy Roosevelt. Eisenhower repeated them. Goldwater, this was conservatism. What's called conservatism today isn't anything like original American conservatism. That's the conservative voice that will get people in Utah to embrace this, even though they will remain different in their values than, say, people who live in one of the bluer states.
To be fair, though, in the atmosphere of 2009, okay, in 2010, but due to the bifurcation of politics, okay, at that time, and specifically McConnell's control, okay, the Senate, it was going to be very, very hard, simply because of his control, to get any Republican votes. I mean, I don't think, they would have gotten any Republican votes if Obama, had stood on his head for days in the Senate, because Mitch was dedicated at the time to making him a one-term president.
Right.
So it's a very poisonous sort of environment. Now, it could have been helped with the state-based the single-payer approach. In other words, a healthcare reform plan that simply focused on the states coming forward with their own programs, and allowing states to come forth with different kinds, of programs, seeing how they worked, but taking a laboratory approach, essentially. That might have pried a few votes away from Mitch McConnell in the Senate.
Yes, I agree that the politics, as embodied by Mitch McConnell and others, many others in the Republican caucus, in both houses of Congress, those are not votes that I'm going to try to get. But I'm going to remind you that John McCain was a vote that could have been gotten. In fact, 4 years ago now, when he very famously put a thumbs down on the skinny repeal of Obamacare,
yes,
this is what he said: "Our health care insurance system is a mess. We all know it. Those who support Obamacare and those who oppose it. Something has to be done. We Republicans have looked for a way to end it and replace it with something else without paying a terrible political price, and we haven't found it yet. And I'm not sure we will. All we've managed to do is make more popular a policy that wasn't very popular when we started trying to get rid of it. We've tried to do this by coming up with a proposal behind closed doors in consultation with the administration, then springing it on skeptical members, trying to convince them it's better than nothing, asking us to swallow our doubts and force it past a unified opposition. I don't think that's going to work, and it probably shouldn't. The Obama administration and congressional Democrats shouldn't have forced through Congress without any opposition support social and economic change as massive as Obamacare. And we shouldn't do the same with ours. That's a vote that's gettable. There aren't very many of those, but we need to find them and elect them and then get them to help us. That's what we've got to do.
But to remind us all, though, the situation in 2009, 2010, there were elected at the start of that Congress, the 58 senators who were Democrats. If they could have pried loose 4 or 5 from the other side, that would have been a filibuster-proof thing.
Yeah.
And had they come forward with a program, I suspect that if they came forward with H.R. 676, but also had given the states the option to create their own single-payer plans, if they didn't want to go with the national plan, that something like that might well have worked to pry away those 4 or 5 votes on the Republican side.
They could have melded together what is today H.R. 3775, which is the State-Based Universal Health Care Act.
The Ro Khanna bill.
The Ro Khanna bill. They could have melded that together with a Medicare for All and given states, those that chose to, just like the OSHA law allowed there to be state plan states and federal action states under OSHA. If they had done that, they might have gotten exactly what you're suggesting. McCain and a few others, and passed something that would have had some staying power because it could have been argued it's bipartisan.
Right. So the real truth is that what happened in 2009 and 2010 was that on the Democratic side, that party was controlled by the donors, and Obama wanted nothing to do with the single payer program.
Right. He became his own worst enemy.
He did. He did. He took the single payer program off the table even before he was inaugurated in January of 2009.
Very carefully documented by Frontline on PBS.
Yes. Yeah. He and Max Baucus decided there wasn't going to be any single payer.
And shut it out. So.
And shut it down.
Yeah.
And that is what happened, okay, at that time. He even tried to exclude John Conyers from the conference on healthcare. That occurred later. I forget when it was, in February or March, okay, of 2009. And he didn't want John Conyers to come. Okay, Conyers managed to crash the conference anyway, but of course he got nowhere.
Yeah.
So Lisa says, one nurse cried in tears in front of Connor Lamb, saying this for-profit system has turned her into a thug. I thought that was an interesting comment.
Yeah. The Bible, the biblical wording for that is, they rule us with force and harshness. That's a quote from Ezekiel about how we are failing to strengthen the weak and heal the sick because we're being ruled with force and harshness.
Speaking of force, okay, and harshness, there's one thing, okay, that was favored actually by Ezekiel Emmanuel.
Oh, yeah, okay.
Who was featured, okay, a little bit at some part of the video you did. He's very famous for the idea of introducing value-based healthcare into the system. And there's a recent video done by two very young people, whose names, are Ali Alexandra and Seb 2 Solomon, something like that. They did a study, a detailed study. I can't say how careful it was, but it was a detailed study of the way CMS is applying the idea, of value-based healthcare. And this video, which I can send you a link to, is very interesting, in terms of pointing up the indicators that are being used inside of the Medicare system today by CMS. And just from the standpoint of an indicator's point of view, I have a background that includes a lot of work, in indicators, in measurement theory, but generally speaking. And I can say that these indicators, it's just not clear what aspect of value they are trying to measure.
No.
The indicators don't look like they are valid measures, of value from a healthcare point of view, at all. They seem to be indicators of how you triage healthcare to produce a low-cost result, but not at the same time to create, a quality result. Anyway, this video they had some days back, It was very dismaying because the context, okay, they put it in was that HR 1976 is supposed to have turned over the administration of healthcare once again to CMS. And the issue is, were the value-based standards that I guess were introduced into CMS, but through consulting, okay, with Emmanuel, whether those standards were going to be carried over to HR 1976. Okay, and the two ladies were very concerned that if that happened, this was going to be very bad for the implementation, okay, of Medicare for All, and would lead to failures.
Yeah.
I thought that was quite interesting, actually.
I think the value-based care model is failing. The accountable care organization model is failing because it's arranging deck chairs on the Titanic. It's not actually reducing overhead, and it's not getting right to the bedside and trying to figure out what's going wrong that causes people to be injured, to receive care that's not clinically indicated, and to not receive the care that is clinically indicated in a consistent fashion. I've got some illustrations in that video that you mentioned, which is on my YouTube channel. It's about a 37-minute long piece, and I illustrate it with a story about the care of pneumonia in a small hospital in central Utah, where a family physician recognized from the bedside that people were getting sicker with pneumonia than they should be, that it was something that he could do something about. And he came up with a protocol, got everyone in the town, all the other docs to agree to it, got the hospital administrator to agree to it, and implemented it, and instantly saw a drop in the number of people sick enough to need hospitalization, the number of people who got hospitalized who had to be in the ICU, the number of days in the hospital if you had to go in for pneumonia. All of these things improved almost instantaneously, and the cost per case of pneumonia dropped in half. And yet the perverse incentive of the American health system found that hospital taking a financial hit because they were caring for pneumonia patients in a better fashion, in a more quality-oriented fashion. They were getting reimbursed less than the drop in the actual cost per case. So they took a financial hit. This is the perverse incentive of the for-profit, better sell something healthcare system that we have. We put at risk even the best efforts to improve quality. We've got to change how we do the financing in order to put an incentive in the hands of doctors and nurses who want to do the right thing for the patients so that they are free to do real quality improvement.
Yes, but thank you. That was a wonderful comment. Laura Fielding says, I think whole Washington understands that we place the initiative process at the heart of our work. With clear eyes that it's almost definitely how we will pass it, and we use the legislative process to our advantage as another route by which we can apply pressure. For example, we're shifting focus on demands that the Senate Healthcare Committee schedule us a public hearing. So that's going on in Washington right now, Laura. That's what you're working on. And Lotta says, Dr. Jarvis' book, The Purple World, Healing the Harm in American Healthcare, is also on, I think, it's Audible, published in 2018. Jeffrey said, Denton says, let's remember, he's talking about polling support now, was strangely frozen at 70% before Medicare for All, among all Americans 4 years ago. It was at 52% Republican support, as well. So I think Jeffrey is saying that the polling support level seems to have been frozen for 4 years, and he is doubting the validity of the polls. He thinks it's very unlikely support um, has not changed, either gone up or gone down since that time. But I think his opinion is that it most likely has gone up since that time. I would certainly think that would have, especially given the COVID and the sufferings people, are having now, and the financial difficulties some are having now in coping with COVID. Comment?
Yes, I, I do think I share the frustration of what that comment implies, which is we have a consensus developing for many years now that something's really wrong. And increasingly, with the help of Bernie Sanders, who actually has made single payer a term that more Americans understand, increasingly people recognizing that something's not being talked about in the major news outlets at all that deserves more focus. So when they poll, of course, pollsters can ask questions in a variety of tricky ways
It certainly
that end up destroying the any sort of reliance or feeling of confidence in what their findings are. And yet I have more and more and more family, and again, I'm surrounded by very conservative people who are articulating things that you've heard me say tonight. Why isn't that being reflected not just in polls but in actual outcomes in elections? We in the movement need to do a better job of translating the health insecurity that is generally felt into a voting majority that will, if they don't have a true sustainable health system reform candidate to vote for, will throw out the incumbent just on the principle that they've already been there and failed at it and will give someone else a try. We have got to get a little bit more pointed in the way we attack the politics of health system reform. We're not going to get help. This is a movement, unlike any other civil movement in the past history, that's opposed by a massive corporate welfare state. That is unprecedented. The kind of uphill battle that we got, the heavy lift that we got, no one has a model for it. We have got to start actually translating our concerns and helping people who are our colleagues translate their concerns into throwing people out of office. And I don't care which party they're part of, because both the Democrats and the Republicans are failing us on this. Throw them out. Start over with someone else. Let's start actually doing what we have to do and stop letting them tell us nonsense about health system reform.
Yes, I completely agree with that. And there's also, we have to mention here, have to note that there's also a close alliance between the politicians in the mainstream, and the media. And it's kind of an iron alliance that we have to break up, because the media is owned by big businesses today,
right?
And they have determined that they don't want to talk about certain things, and one of the things they don't want to talk about is single payer. That's become
Wendell Potter has done a good job of helping us understand how what is written in the boardrooms of the American medical industrial complex is that afternoon on the tongues of our representatives in Congress, and that's what passes as news on that night's news reports across the country. That is unacceptable. We've got to stop believing that parlance and instead saying to those people, you haven't helped me. You haven't done a thing for me. You're out. Okay, I don't care that I've been a lifelong Democrat and you're a Democrat. You're out. I'll go with anybody other than you. You failed. Let's get moving and let's push these people away.
Just a few years ago, I was advocating. I was getting very, very angry. And I wrote a blog post. And the idea behind the blog post was to Okay, it was really very simple. Okay, the idea was vote for the person who has the least amount of contributions backing them. On the theory, of course, that the people with the money, generally speaking, are the people who have contributions from the corporations, okay, and from extremely wealthy people, okay, as well. And so they're much more likely to be doing the bidding, okay, of those people. So the idea was to vote for people who had very little money and who were campaigning on good things for the people. That was the combination, okay, to vote for. That implied, of course, that most of the Congress people, most of the office holders we currently have would be turned out. What I was arguing specifically was if we all voted that way in one election, even, it would change the political system. If we threw out 75 to 85% of the Congress in a single election, they would change their behavior. They would have to, okay, at that point. And that's what we need. We need behavioral change.
You know, I've gone around recently and talking about the Harris-Wofford moment as an illustration of what you're talking about. It wasn't 75% thrown out. It was John Heinz, the then Republican senator, dying suddenly in a helicopter crash, a Democrat governor in Pennsylvania having to replace him, appointing his own Secretary of Labor, Harris-Wofford, who was an unknown, to be that replacement, but knowing that he was going up against a very popular former Republican governor who was then serving in the Bush administration as the Attorney General and who started that special election with a 40% lead. And basically saying, I don't think Harris-Wofford could ever win this. He can't come out from 40% behind. And all Harris-Wofford did was go around saying, look, if you commit a crime or someone alleges you did, you have a right to an attorney. Why don't we have it the case in this country that if you're sick, you have a right to see a doctor? And he struck a nerve, that health insecurity nerve I've been talking about that's rampant throughout America. And he came out of nowhere and won that race by 10% and immediately changed everything everybody thought about healthcare reform in Congress. Bill Clinton was beginning to formulate his next year's presidential aspirations, and he changed everything and ran on healthcare. Now, I'm not saying that Bill Clinton ended up doing the right thing with the Harris-Wofford moment. He didn't. But Harris-Wofford won that race, and from then on, first-term presidents have had to run, at least in part, on something that the American people needed in healthcare. It was Bill Clinton, followed by George W. Bush, who ran on Medicare Part D, and then Barack Obama running on what became Obamacare, and even Donald Trump saying, contrary to every other Republican presidential candidate, I won't do anything to Social Security and Medicare. I'll save them for you. That had to happen because Harris-Wofford made that happen. If one race can make that change, think of what we could do if we could get 2 Senate races turning on this, or 10.
Right. Okay. And think of what we could do if in a single election we could turn out 100 incumbent congressmen.
Right.
What that would do. That is so important, to just vote against incumbents with very few exceptions.
I'm absolutely with you. I had the talking points that I gave to the healthcare caucus of the Utah Democratic Party. And remember, I come from this as a former Republican. I left the Republican Party in 2016, but that's where my political beginnings are. So the fact that I'm speaking to the Democrats is a little bit unusual anyway. I said to them, don't vote for an incumbent. If you don't have someone clearly to vote for because they're articulating single-payer health system reform, at least vote against the incumbent. Do that. Change something. You can't keep complaining about how terrible Congress is and then re-electing your own congressman. That just doesn't fly. Nothing's going to happen. This is why I'm starting to try to recruit friends to help me start political action committee explicitly and exclusively devoted to this kind of politics that hopefully we can translate across the country.
Oh, that sounds great. That sounds like a wonderful move. Okay, Dolores Pierce says keeping people healthy keeps the medical costs down. Only a for-profit system gains from intentionally keeping its citizens sick. Of course, that's been one of the big incentives, I think, in our medical care system. They want to keep us sick. They want to keep us on pharmaceuticals.
This is what I meant when I said perverse incentives, and why a hospital that figures out, like this small Central Utah hospital did, about how to care for patients with pneumonia and keep them from being so sick that they ended up having to be hospitalized or in the intensive care unit, but they were financially penalized. If that were most hospitals in the United States, what that would have meant was they would have jettisoned that program, because current modern day business motives in American healthcare is make a sale, don't care for a patient. And if your sales that are the most profitable are you ICU sales, then let them get sick. That's how it works. Or actually doesn't work for patient care, but that's where the profits are. Sorry to say that, but that is the reality of American healthcare. We'd rather make a sale than take care of a patient.
That's just terrible, folks. That's just terrible. We know it has been going on. We've been seeing it for a long, long time. And the only way to get rid of those incentives, I think, probably the most basic thing we can do at first, is to get rid of the politicians who, in their own way, have been reinforcing those incentives and creating those incentives with the kind of healthcare system that they created. As Lisa says, the neoliberals will live and die by the ACA legacy, by the Obama ACA legacy. It's going to end them. The only exception I would take to that is that's not the only thing that's going to end them. All kinds of neoliberal things that have been going on, are beginning to end them, because everybody can see that our system is bankrupt, not only in the healthcare sector, in the energy sector, in sector after sector. Our system, is failing. It's enriching people. It's failing to serve the people in general.
Is that it?
Hmm?
Is that it?
Okay, more comments. Kit Burns says, rather than lower the age of Medicare, I prefer the Medicare expansion is for 100%, no copay, no deductible, no pharma costs. Then gradually lower the age. That's a position I've been hearing from more people the last about 2 or 3 days. I suppose the response I have to that is that I don't like the incrementalism that is inherent in that. If we look down the road, if we get an expansion for 100% for people over 65, that's great for me. I'm way over 65, so it's wonderful for me. But if we take little steps like that each year, it will be a decade before we get to a Medicare for All system. And meanwhile, people will continue to die. We cannot have people continuing to die because of the healthcare system that we have now. That is really the bottom line, okay, for all of this. I was very concerned about the fatalities, okay, among people who did not have insurance. Okay, so I estimated the likely level of fatalities that occurred because the Obama administration failed to pass H.R. 676. I estimated that for the years from 2010 to 2016. And the figure I came up with, okay, is an estimate, okay, which was based on various studies that people had done that seemed to show there was a ratio of the fatalities to people of 1 to 700, okay, in 81. Anyway, I used that, okay, to do the computation. I came out with 356,000 fatalities due to the decision to take H.R. 676 off the table in 2009 as soon as Obama came into office. 356,000 untimely deaths. Okay, just attributable, okay, to that alone. And that doesn't take into account the deaths that were due, okay, to inadequate coverage and deaths that were due to the medical errors, okay, as Dr. Joe has been talking about.
You know, I can't, every incremental fight is a dissipation of energy that ought to be devoted to getting everybody together on the same page, because we all have health insecurity. We all share that. We all need hands-on. We all need the care that real health system, sustainable health system reform will provide. Let us fight the fight together. Let us fight on all fronts together. Let's put everybody together.
Yes.
Let's help everybody understand we're doing this for all of us. That everybody
One of
needs
the most powerful things the Medicare for All people have to say is the simple slogan, everybody in, nobody out.
That's how our political fight will be won. Everybody in, no one out. That's exactly right.
Yes. Yeah, I've been hearing that slogan since I went to a protest in 2009 that was run actually by the PNH people in Washington, D.C. Okay, Margaret Flowers and Kevin Zeese were there.
Right.
At that time, Dennis Kucinich was there. Carol Paris was there.
Right.
It was a very powerful protest in front of the White House. So I'm just scrolling down here to see which of the questions seem to be most relevant. So Lisa says LIP, I'm not sure what LIP is, made a great the critique today on the California bills thwarting that continues. I'm not sure who LIP is, but maybe, oh, I see. She's trying to say Kip.
Right.
Kip Sullivan had a critique today on the California bills thwarting. Have you got a link to that, Lisa? I'd love to see that critique. Mitch caused the operations of government to deteriorate into what is called what is called obstruction. Yes, it is called obstruction. That's because it is obstruction. And Dolores Pierce says, to think I made phone calls and knocked on doors for Obama. My daughter and her friend learned a lot from being with me. I'm knocking on doors and listening to people in the phone room. There was a kids' room next to the room where I phone banked. Just a little piece of experience. There were many of us who supported Obama and who later on greatly regretted it. Greatly regretted it.
That's true.
Okay, and I guess there's a question. I'm not sure, how relevant it is, but during the election of 2012, the choice of Obama, and Romney, have you, an opinion on what things would have been like for single payer, if Romney had won that election?
Do I have an opinion about that?
Yes, do you have an opinion about that?
Well, Romney has never been a single payer supporter. And I have recent experience speaking with his staff about the state-based Universal Health Care Act. It's a tough sell in that office. They are considering the possibility that states ought to be allowed to have the option to create that, because Romney has repeatedly said what he did in Massachusetts, which we all know was very Obamacare-like, was explicitly for the state and had nothing to do with imposing it nationally, that every state ought to have its own ability to look. So, I mean, he's already out there in public making that statement. That is a window of opportunity for single payer, because a state like Washington achieving it with the help of Senator Romney voting for the enabling legislation will show the rest of the nation how functional and how wonderful that transformation will be. Lots of more states will gallop through that gate. Is that possible? Would that possibly have happened with the Romney administration? Yes, and it clearly didn't happen with the Obama administration.
No,
So
clearly.
that'd be my answer to that question.
Okay, good answer. Okay, I'm scrolling through. Jeff Denton says, I have a list of 116 countries around the world that have a universal healthcare system. But why isn't the wonderful media that tells us the truth now talking about it? Well, I guess we know the answer to that question, Jeff, don't we? Okay, Lisa says, Bernie's bill is so much better, it will be reintroduced in the fall. But Lisa, are you suggesting Bernie's bill is going to be so much better than HR 1976? Do you know that? Is it going to include nursing home care? Because nursing home care is included in HR 1976. One of the most attractive features of 1976 is that it won't be necessary for people to practically go into bankruptcy to get nursing home care. That's a really important feature of that particular bill. Okay. Okay, bankruptcy, is mentioned here as a very important effect of the current healthcare system. Okay, and of course it is. Laura Fielding says, thank you very much to you both. Let's have these conversations with our friends and family. Yes, we certainly do, and I think we certainly will. And Lisa Girl says, preach, Dr. Jarvis. Karen says, hi, Lana, having nonstop headaches, migraines actually. But I feel another one coming on, so I apologize for not engaging much. Nice that you're here, though. Okay, Lana says, I voted for Obama twice. Now I can't look at him without a disgusted look on my face. Well, all I can say about that is you're not the only one. Laura says, when you finish up the comments, please, both of you, head on over to Twitter and see what an amazing person Twitter volunteer of whole Washington has done with Kenny Ballantyne's recently recorded M4A strategy panel that Dr. Jarvis was part of. He's broken it into 2 minutes and 20-second chunks on a happy birthday Bernie thread asking him to endorse. That sounds like a wonderful thing to have done, Laura. A really wonderful thing to have done. And I will certainly head over to Twitter to take a look at that. I'd really like to see that. Because, by the way, that strategy panel was terrific.
Yes, that was a good group of people. I enjoyed being there with them.
Yes, I think they enjoyed your being with them tremendously as well. That's the way it looked to me. Carmen said, Dr. Jarvis, yay or nay on the subject of ivermectin to help treat COVID-19? I jest, of course, but if you want to answer the question, I'd appreciate it.
Ivermectin doesn't have clinical science behind it as a treatment for COVID. If it ever does, then of course use it. But until it does, it hasn't passed the smell test and it shouldn't be used.
How about the idea that even though it doesn't have the clinical science behind it quite yet, that but given the fact that when used in the kinds of doses that certain doctors are recommending for it, it's very unlikely to have any side effects that are harmful. So some of these doctors are arguing, but why not see if it will work for some people?
Well, they're making an assumption that their observations about safety are, in fact, correct.
Yes.
Clinical science, clinical trials are designed to first verify safety, and that includes by dosage, and then secondarily to figure out if there's efficacy. And neither kind, as far as I know, neither kind of study has been conducted. So I don't accept as a premise the notion that it's been proven to be safe at any given dose until someone actually does the trial.
But fair enough. But isn't there a very long history of using it for other purposes that shows that in those same kinds of doses, that it has been used for, that it is safe?
Well, it has approval for certain uses, yes, but we have people with a virus that has been proven to be a remarkable new threat to their life. And in that setting, that might be a different experience. I suggest again that we have carefully developed clinical trials as a way of proving safety and efficacy, and let's play it out. That's what those trials are supposed to do.
Right. But what if there's a problem in getting funding for the clinical trials, which seems to have been the case with respect to ivermectin?
Yeah, that's always an issue, and I regret that's an issue. But I can't, in a public setting like this, I can't endorse something that doesn't have science behind it. We've got to trust science. That's what this is all about.
True. This is what it's all about. So Laura says, we enjoy being anxiously engaged with you. Anxiously engaged. Is that correct?
Yes. That comes from the scriptures of the Church of Jesus Christ of Latter-day Saints, my faith tradition. That's a term comes right out of what that particular scripture is called, the Doctrine and Covenants. And it's one of my favorites. So I have used it on occasion.
Okay. Ghost Art says, #Occupy Congress. And Carmen says, Florida did do a study. How many people were involved in that study, and where are the results, Carmen? And was it a double-blind controlled study? These are questions. In other words, did it meet the gold standard, of methodology for studies of this type?
How could it?
So those are questions that have to be asked. No, I'm asking this question of Carmen.
Yeah.
Okay, whether she has seen some documents on this that suggest that this was a good scientific study.
Okay.
As I said, as far as I know, the funding has not been available to do a decisive scientific study, okay, about this. And you would need thousands of people involved in such a study to get the kind of evidence. You would need probably 20 to 30,000 people in such a study. Okay, I think we've come to the end of the comments. I think we've come to the end of the program.
Okay.
Dr. Joe, thank you very much, okay, for being here and for staying for all of the questions.
Hey, thank you for having me. It's been great.
That was a pleasure, certainly. So everybody, good night. On Saturday, I'd like to remind you, Sharif the Snugs is going to be here on Saturday. Tomorrow night, I will be here, and I'm afraid I cannot avoid saying something. In fact, by saying a number of things concerning the crisis that has been brought about by Texas and by the non-decision of the Supreme Court with respect to the new Texas law. I'll have a number of things to say about that. Those things will include ideas like jurisdiction stripping, and include also some other ideas about what kinds of bills should be passed. So I think you'll find it a very interesting program tomorrow. I'm going to go over a lot of crazy ideas which have been coming out of all sources, but since the non-decision came down from the Supreme Court, and since the state of Texas, okay, was allowed to go ahead with its plans. So I'll see you tomorrow night for that. And now, good night. I'm going to end the broadcast. Okay, Dr. Joe, if you could stay a moment longer.
Okay.
I'm just going to end the live stream broadcast.